right, and that brings us to our final talk of the session today. Dr. Vaccaro will talk about contemporary management of postoperative spinal infections.
Wow, this is the last talk of the day. Congratulations. All you guys did a great job. This is a great meeting. I do a fellow meeting every year, but we don't really talk about facts or anything, and the learning is not that good. But this fellowship meeting has really done a great job. I've learned a lot by it. Everyone's phenomenal. So it seems like everyone's either a USF fellow or a Larry Lanke fellow. Is that how it goes around here? So I'm going to talk about something that I have a major conflict with, and that's getting infections, and I get a lot of them. And we got a lot of them at Jefferson back in the days of spinal cord injury. So who does a lot of spinal cord injury surgery in the audience? So I would say about 20 years ago, our infection rate was about 10 to 12% in the setting of spinal cord injury. And then we came up with the magic dust, the vancomycin. We blamed everything on the hospital. Remember, the hospital will blame you as a surgeon when the infection rate is high, and then they look at it, and then it goes down all of a sudden. It's because they're finally cleaning the instruments in SPD. So keep that in the back of your mind. So there's definitions of superficial, incisional infections, deep infections, organ space infections, and then there's definitions for timing, early, less than 30 days. You can see people who are symptomatic, red, swollen, draining wound, late, greater than 90 days. And the most complicated thing is a patient that comes in that is clinically ill and the wound looks normal. That's a headache. So that's your biggest problem. So someone comes in, and I'm not talking a year out, I'm talking about like 90 to 100 days. Everything looks normal. You get a CT, you get an MRI, you don't really know what's going on. So what do? Do you biopsy? How do you go? And I'll talk about all the little headaches that we have with infections. So it's easy to differentiate between early and late in terms of the drainage, and late in terms of implant retention or removal. But those are the issues that we do. So the basic facts. Patients do not like getting infected, and when they get infected, they think something went wrong, and they're not happy. So keep that in mind. They're not happy at all, and they think that something went wrong. So right off the bat, you did a great scoliosis operation, and now everyone's in a bad mood. So I'm going to tell you a few little caveats about communication. We don't let our fellows dictate. Do fellows dictate at your program the operative report? I have to control the speech. And I remember my fellow dictated a post-op infection, and I read it like a week later, and it said there was copious amounts of purulence. And I'm like, okay, why don't I just sue myself? I would go, that is not a good way to dictate. So you want to play it down. If you cut that incision and pus comes out and hits your face and you have to scrub again, you go, it didn't look that bad. I think you may have an infection. So you have to, but it bums people out when they have it. And there's a couple of studies that looked at how people do in terms of outcome, and the infected group, and this is the thing, the infected group often doesn't do as well as non-infected patients, but at about 6 months to a year, they equalize. So this was the most recent study, 2021, JBJS. At 6 months after, the outcomes are about the same, but the infected group had higher incidence of complications. So they don't do as well. And it's the other thing that talk I give on dural tears. I always want to say to a patient, the outcome from a dural tear is just as good as if you don't have a dural tear, as long as you adequately repair it. But a lot of studies do show that there may be somewhat of a decreased outcome, so we have to keep that in the back of the mind. So these are all the papers published. Now, 3 up from the bottom, that's out of our institution. Campbell was a neurosurgeon. So we had a problem at Jefferson back in the 80s and 90s. We were at our hospital, we would get 2 to 3 spinal cord injuries a day come in because it was a tri-state area, and things were not going well. And that was before vancomycin and stuff like that. So we always sort of prep the patient. If you're immunocompromised, if you get blood transfusions, or if you have a spinal cord injury, your risk of infection is high. Now everyone knows the risk of infection. So if you have a lumbar decompression at Thomas Jefferson, it's 0.7%. If you have an instrumented fusion, it's 1.35%. You sort of memorize it, and every month, I'm sure your hospitals do the same thing. They kick out the data. Those are the known risk factors, patient comorbidities and procedures, and nothing's unusual in that setting. I mean, there's always controversy on types of interbody implants. PEEK develops biofilms and increases the risk of infection. Titanium doesn't, but who knows? But everything up there is what you want to deal with. The things that I tell people to focus on, look at the fat tissue that you have to dissect through, keep the patient's glucose in a reasonable manner, and I'll talk about the controversy about testing the nares for MRSA colonization. So we have published on this subcutaneous fat thickness. I can predict when I'm going to get a posterior wound infection. When you dissect a half a mile to get to the spine, you know that you're going to have a problem with that patient after surgery. Preoperative injections of steroids. These are papers that we published out of our institution that basically looked at, people say, Doc, I know you're going to operate on me in 2 weeks, but can I get a lumbar epidural steroid? And I said, listen, studies have shown if you have a lumbar epidural injection within the first month and a half to 3, it increases your risk of infection. So that's the line I give now. I say, listen, you can have it, but it may increase the risk of infection. Other studies we published, case order, the room gets dirty. It's so funny, at a teaching institution, and I have one of the reps from Medtronic sitting here, we must have 10 to 15 people in complicated cases. And I look around and I go, this patient's getting infected. I mean, the doors are opening and closing. So we've noticed that Thomas Jefferson, if you're the last case of the day, your infection rate increases. And we also noticed, and I don't know if it's the hotter months or the beginning of a residency program, our infection rates were higher, and we published on that. I think many of the authors talked about the frailty index. If frail patients are more susceptible to being immunocompromised and more susceptible to infection, so we know that. And if you look at wound infection rates, it goes up significantly. So again, whatever you can do to improve the substrate and improve the health of a patient, you want to be able to do that. And surgical invasive index, the more you do, the longer that patient's in the operating room. And I say it to all my fellows, you keep someone on an operating table a longer amount of time, that's a problem. Increased blood loss, that's a problem. Exposure to anesthesia, that's a problem. And the interesting thing about minimally invasive and open surgery, and we looked at outcomes, it's really the time under anesthesia. So if you become a well-trained, facile surgeon and get someone off an operating table, those patients tend to do better overall and their infection rate is better. Infections, it becomes a medical legal problem in a delay in diagnosis. And just like a lot of the problems we have, especially if the wound doesn't look bad, don't blow it off, don't blow it off. We're really aggressive. And again, you get darts thrown at you if you go back to the operating room. We have all these process measures now, readmission, re-irrigation, debridement, and you can see doctors getting penalized for taking patients back, but I'm still aggressive. If a wound looks bad, I will revise the wound, because I don't want the patient to come back every week and all of a sudden I have a greater problem to deal with. So you want to be aggressive. Now, the bottom line, Cutibacterium acne, which used to be called Propionibacterium acnes, we actually think that may be a cause of significant back pain. If you see a modic type 2 change on an MRI scan, we culture all those discs now to see if they're positive. It may just be a burnt out P. acne infection. But these are the common infections you see: MRSA, staph epidermidis with spinal instrumentation, gram-negative bacteria. And again, I tend to be biased. I don't blame it on an adequately trained surgeon. When I see the infection rate go up at my university, there's something wrong with SPD, there's something wrong with the sterilization process. And today, when I was at lunch today, one of the nurses sent me a company's implant. He said, listen, we're having a hard time cleaning this implant. And I said, congratulations. I said, that's where I think personally the infection rate comes from. It's not from the fact that you've broken a sterile protocol. It's because we irrigate the wound, we go through, the chlorhexidine wash, we give preoperative antibiotics at the appropriate timing. I'm assuming you do everything right. When you see fluctuations in infection, there's something going on at the hospital. Now, this is sort of fiction. People look at the timing of labs, white blood cell count, SED rate, C-reactive protein. They are usually a lot higher at our hospital than documented, and they do not normalize by post-op day 7. So don't get caught up to this. I use these indices to see if I do have a patient with an infection, how are they manifesting with treatment? Are the labs going up, or the labs going down, in addition to renal function? And there's other things out there, serum amyloid, procalcitonin, and then the pre-sepsin. Now, I don't use any of those. These are just for academic reasons. But these are the things that you look at. Again, I don't get nervous when the labs are high, because I don't know anyone who, if you do a deformity surgery that comes in 2 weeks, their SED rate is normalized. I've never seen that happen before. So I don't give much credence to that. Now, it's interesting. I do use MRI, T2 weighted MRI, when I'm looking at the lumbar spine and someone I think may have an infection, but the wound looks great, I look for the pedicle screw sign in a T2 weighted image. I think that's a great thing to do. And the times that I've seen it, the fluid collection around the pedicle, those patients have been infected. So the top line is that little halo that you get around someone with an infection, and you don't see it in a non-infected patient. So I now prospectively look at it. So when I see a patient that has, I can't really tell what's going on, I could always do a biopsy, but this is a great little thing to do. And then the PET scan I don't use, but all the literature that comes out that looks at the PET scan and how effective it is in infection, you can see patients that come in, it may light up. Now, it's interesting. If you go to California and to Los Angeles, and you see a lot of the arthroplasty doctors talk about PET scans and SPECT scans and what it means, and I'm always like, oh, that doesn't mean anything. You know, I look at, I don't believe in it. But in the setting of infection, a PET scan may be effective. So I haven't used it, but it's something I'm going to consider in the future. Now, are there little tricks you can do? Can you put something in the wound? Can you use a special type of suture? How long do you put the bandage on? When do you let them? If you look at the literature, nothing correlates with any evidence-based medicine. So every hospital has a little trick they use in terms of what postoperative dressing they use, how long do you keep it on. We take all the dressings off the next day when the patients leave the hospital, in 24 to 40, everyone's allowed to shower. I try to remove the drains as soon as I can. The only case that I get nervous with drains is when I'm doing a posterior cervical case, because those patients can get paralyzed 2 to 3 days. They reach a certain point of fluid collection, and I've seen those patients get paralyzed before. So that's the only case that I'm really nervous about taking a drain out too soon. But most drains are taken out at 24 hours. And then in terms of the DMARDs, it's usually not a problem for a non-biological DMARD, but a biological DMARD, they have to be stopped before surgery, and they have to be contingent on their dosing cycle. So not many medications I worry about for infection, but the DMARDs are something that most of the literature has looked at and said it can be a problem. You want to normalize a patient's glucose level. That's an important thing. So diabetics, which are hemoglobin A1C is out of whack, just give them to the medical care provider, try to get them within alignment. And if you can't do that, then you have to sit down with the patient and say, listen, your glucose is over 200. You will get a postoperative wound infection. So I sort of tell it to them right up front, you will get an infection. So you want to make sure that you keep the glucose in line. Now, this was something really hot about 5 years ago. Everyone in our hospital had their nares cultured, and if they were MRSA positive, they got mupirocin for a while. I hope that's not my kid out there. They got mupirocin before surgery, but what we found at Jefferson was you couldn't control if the patients were getting it for 5 days. So it was all over the place. So our infection committee in the last month said, we're no longer testing. We're no longer testing if you have a decompression alone to see if you're a carrier. You're only getting tested if you're getting instrumentation, and we're not treating anymore with mupirocin anymore. We're going to give Nosin, which is a sort of an alcohol-based thing, and then we'll treat with vancomycin. So that's interesting, and I'm sure we're the only hospital that are doing that. But if you look at the bottom line is MRSA swab instrumentation only, and if you're positive, we don't give mupirocin anymore. We treat it with vancomycin, and we give Nosin, which is it's an alcohol solution. And again, I've argued with the committee. Now, if you know Jay Parvizi, he's my partner who comes up, he does all the infection. He said it's a waste of time. Only 12% of patients take the mupirocin for 5 days. Once they leave the hospital, you're wasting money. There's no evidence that. So he was on the committee that said, stop it. So that's something we're doing at Thomas Jefferson at the present time. But colonized patients do have an increased risk of infection. Non-colonized patients have a lower rate of infection. In terms of what do you use DuraPrep or do you use chlorhexidine? We use chlorhexidine because it's been shown to be more effective than a betadine base. So that's what we use at Jefferson. Everyone gets some magic dust. We've been using it, and there's so many conflicting articles, but most of the high-quality articles, and I have them right here, show that vancomycin does make a difference. I've seen many papers that have said it did make a difference. We've noted a dramatic decrease. Now Jefferson has the average infection rate of the rest of the country. We're always higher than average, but now it's the average rate. So, and I thank that for it. I have no idea what sodium oxychloroquine is. Anyone knows what that is? This was just published in the neurosurgical literature. Anyone use it? So I just thought it was interesting. It was a well-done study that looked at a large number of patients, 5,047 patients. So that's something we'll look into. In terms of antibacterial resistance, we haven't seen any vancomycin-resistant bugs that have come out, but we have noticed that the patients that do get infected usually have a gram-negative infection, and that's what the literature bears out. NAS supports it, as you know. And we do, in a patient where we're really concerned about a gram-negative infection, we'll throw tobramycin in addition to vancomycin into the wound, but you really have to watch for renal function. So tobramycin in addition to vancomycin, and it has an improved activity against pseudomitis and so forth. Tissue sampling, this is just, again, out of the J-Porvisi. If you're going to send samples, make sure they're tissue samples, make sure you have multiple samples. And the most important thing is always make sure the resident fellow calls the lab at the end of the case, because 10% of the time, the next day you'll check and the lab never received a sample. So always call right from that operating room to make sure they have it. My biggest nightmare is if you have an interbody cage in and you have a deep wound infection. What do you do about the cage? I tended to be very aggressive and I tended to remove the cage. Most of the literature says that you don't have to do that, thank God. So, and it can be, and I've tried to pull cages out, and they're very difficult if you place it from posteriorly, and it's even worse if you place them anteriorly. But usually it's not a problem. Algorithms, it's interesting. Early versus late, how many washouts you do. I tend to be more aggressive. I like to wash someone out every 48 hours, put a wound vac in. Once the wound looks good, then I like to close it. I usually consult plastic surgery if I have a deep wound infection. So I'll do 1, 2, maybe 3 washouts. Most of my younger partners will just do 1 debridement. And I always felt, and I get a little nervous by having plastic surgery coming in on the first washout and closing, because if it doesn't work well, they've done tissue flap advancements, and then you have to take it down again. So you've caused a lot of discomfort to the patient. So if it's a late infection, the instrumentation comes out. If it's a short infection, again, you always keep the hardware because you want stability. Infection hates stability, so you want to leave it in. DePaulo was a resident at my facility that looked at this treatment protocol. You add up all the points. If it looks bad, I keep on washing it out. Every 48 hours, you have your partner do it. After about a week or so, you can take the patient back and close them, and it's usually not a problem. The 2 headaches that I have is, should you use BMP instead of an anti-infection? Infection hates BMP for some reason, so we found it to be effective if you want to heal a defect. So all the studies published on BMPs and spinal infections show there's no problem by using BMP, and it also helps the wound, the fusion heal better. So I'm very supportive. So infections are basically our nemesis. What don't you want to happen in the operating room? You don't want the patient to have a neurologic deficit. You don't want the patient to bleed excessively. You don't want the patient to have the post. And an infection just tortures you because the patients come back in and they're upset and the family's upset. So all the things that we talked about the preoperative assessment of the patient, I mean, we're assuming that you get the patient to be the most immunologically competent that you can get. But all the little things I talked about are very important to do. And again, if you do get an infection, blame the hospital. So you guys used to laugh a lot more earlier in the day. But anyway, that's my theory. But anyway, hopefully this will not happen to you. So thank you very much.
Maybe I'll start out. Alex, your partner, J-Porvisi, has really done a terrific job with arthroplasty and really creating some protocols that are, I think, evidence-based and consistent. In contrast, if I look around the room here at all of my partners who I've got great respect for, we all do something different with regard to what we use for perioperative antibiotics to keep the antibiotics down for 24 hours till the drain comes out, till whatever the endpoint might be, what antibiotics we use. And have you done a better job of creating a homogeneous approach at Jefferson?
You will, we have 18 spine surgeons at Jefferson, so we have a lot. And we've all, for some reason, come together at Jefferson and agreed to have a SSI committee. It meets once a month, and we've all agreed to do exactly what that committee talks about. So in terms of what the patient does 5 days before surgery, in terms of their showering with chlorhexidine, the prepping and spew before surgery, the preoperative antibiotics, when to give vancomycin an hour and a half to 2 hours before surgery. The biggest problem is the more senior surgeons will have OR start times at 6:15 in the morning. because anesthesia just starts us early. And getting that vancomycin in early is a real problem because the patient has to get there 3:30, 4 o'clock in the morning. But all that everyone has agreed on. And again, you can imagine Jim Harab from neurosurgery and I'm from orthopedics, and we both fight with each other. So we both kind of sort of battle it out, and we both like to come to compromise on how we should handle it. But there's 5 different areas in spine surgery that you have to get consensus on. Does your institution use steroids in spinal cord injury? Does your institution use traction with a dislocated neck? What do you do for antibiotics? What do you do for DVT prophylaxis? You have to get consensus because the residents and fellows and nurses and PAs are going to make mistakes. And then if there's a legal action, the first thing the attorneys do is, can I see the policy? And then you have to sort of legitimize the policy. So I beg everybody, even if you don't get along, and we don't get along at Jefferson. I mean, we fight more than we get along, but we all agree that we have to get along when it comes to protocols. You got to get along. Because there's really, I mean, the science isn't really there, so you just have to have, and once you have protocols in place, and once you have a dedicated floor and dedicated nursing staff and dedicated OR team, life is smooth. When you don't have a dedicated floor, you don't have a dedicated team, you have different nurses in the operating room, you are there forever, and things go wrong.
No? Okay. So if you have a patient, say you did, whatever, an L3, 4 TLIF, and then they got an infection and osteomyelitis, they kifed over at L2. Now you're going to take them up to T10. What are you going to use for bone graft, you personally, in that situation? They got an osteomyelitis-related fracture, PJK.
Okay, so I'm in my 60s, so I tend to use autologous bone graft. I'm like a big, the younger surgeons have come out, a lot of papers have been written, you could use titanium, it's not a problem, it has no binding. I'm still an old-fashioned bone graft when I can get away with it. If I can't get away with it and I have to go long segment, I'll probably go with a titanium implant with BMP inside the implant, because the literature has been supportive of that. Sometimes I'll go with an allograft, which I don't like to use, with BMP inside the allograft. That's what I'll do anteriorly in that situation. But I'll go with, and you can take, and it's morbid, you can take an iliac crest bone graft that big. You take the top off. I used to take the fibula. I used to go 2.5 centimeters above the syndesmosis so I didn't destabilize, and I would take a fibula graft. You move away from that as you get older. I would never do the rib. I think the rib is the worst thing you can do. Those are for the people here yesterday. Where did he go? Where did Vince go? So that's what I do. So I try to use autologous bone graft first. So then I go to a titanium cage or allograft bone with BMP inside of it. Posterolaterally, I'll use BMP off-label, posterolaterally. And I may, and again, in our hospital we have a protocol. If you decide to use autologous bone graft, you have to open the incision, take the bone graft, close the incision. The nurses will not let you do concurrent surgery. So you have to close that site, and the charge nurse will be in there saying, you can't do it. And that has to be closed before that. And then you put the bone graft and then you use it. That's a problem, though. Yes. Right.
Excellent talk, thank you.
Thank you.
I heard you say something about P. acnes, or the newer name.
Now,
for that.
Cutibacterium.
Yes, and burned out disc spaces with phimotic type 2 changes. So how do you handle
So
that?
when I see a patient, and it really not this talk, but I see a patient with a single level, like I tell my fellows, if you want to have a long, prosperous life, less than 5% of your practice should be back pain surgery. But if you're going to do back pain surgery, a burnt out P. acne infection, which you can't prove, we see type 2 motic changes is the best case to do. Single level L5S1, sometimes L4-5. But I'd always culture it, because that have come back positive. You have to keep it for 6 weeks, but it's come back positive. So I think that is a cause of back pain in some of those situations.
And then do you treat them afterwards with IV antibiotics?
So if we culture something, I do. If I don't culture something, infectious disease doesn't recommend treatment. Just a normal prophylaxis after surgery, because we clean it all out. I'll go anterior. In that situation, I'm going anteriorly. I don't like, if I have a disc space infection, I'm an anterior surgeon. I like to clean it all out. I don't like to go posteriorly because you don't get it all out. You contaminate the posterior wound. I'm going to keep my surgical fields clean, go anteriorly, clean it out, put bone graft. And I will use autologous bone graft, laterally or anteriorly, if I have a disc space infection. So I routinely I'll do a standard lateral approach, but I'll take a piece of bone graft from the iliac crest and use it. And you use a typical implant and disc prep that you would use from any company. And then once you make the hole, then you just put a piece of bone graft in.
What do you do for like an early dehiscence where the cultures come back negative?
I treat it as an infection, and that patient will be treated. The question is, if it's a deep wound, if it dehisces and everything is negative, it's a deep wound infection by my definition, and I'll keep them on 6 weeks of antibiotics. I'll transition over to oral. The younger infectious disease doctors before, I remember I was operating in the 80s, you were lifelong suppressive antibiotics. Then it went to a year suppressive antibiotics. Now the younger ID attendings stop it after 3 months of oral. So it's shortening the duration of time. And I give patients the option of having the implants removed after a year if they want to.
The issue that we're having sometimes is the ID doctors recommend against antibiotics that we're like a weed cell thing.
You mean if it dishisses and it's open?
And maybe, yeah, the cultures are negative.
It's probably infected.
You know, I agree.
Yeah.
When we talk to our ID colleagues, depending on the attending of the week, it's...
Yeah, they usually tell me what they think, but they're negotiable. You know, they call us all the time, what did you think? And I'll be like, okay, I told the patient this, but let me tell you something. Oh my God, I was horrified. I couldn't sleep for 2 weeks. It was horrible.
Just within that line, if you do have a little superficial dehiscence, but you get your MRI and it doesn't have that pedicle sign, do you still revise that wound superficially, or do you just give antibiotics for a time duration?
Without taking it back. If something's dehiscing but it's not bad, I'll treat it non-operatively, wound care, and follow it. And that probably works 70% of the time. But you always prep the patient psychologically, saying, listen, it may not go the way I want it to go, and then I may have to get more aggressive. Yeah, I tend to, I'll see them in the office. The things I was talking about before, the draining wound, you can tell, you know, that something's going to go south. You know, you press on the wound and you're like, oh, that's a problem. You can see that early on. And then a lot of the wounds can open up and do okay.
Do you give post-operative antibiotics, IV?
I do 24 hours. But, you know, a lot of people, most of the cases now are going home the next day. Adult deformity cases are almost going home the next day, maybe 2 days. But rarely any patient stays more than 2 days. I give 24 hours of post-operative intravenous antibiotics on a patient that stays. But remember, a lot of spine surgery cases are going home the same day. And they don't get any antibiotics the second they leave the hospital.
Do you change that if you leave a drain in for 48 hours?
I try to take my drains out at 24 hours. And the only time I'm nervous is only because I'm a man of habit. I've had patients who have done posterior cervical surgery with large laminectomy defects become quadriplegic or quadriplegic at 48 to 72 hours. It seems like, and you open them up and you have that big hematoma. So I came up with a little protocol. So that's the only case that I'm not rational with, because I've had 2 people lose function after that procedure that I had to move pretty quickly. So I leave those drains in longer. You know, most people say when it's less than 30 cc's an hour, a shift, you could take it out. I leave it in almost, sometimes it's 3 days. That's one case that I don't follow the rules on. That has a high risk of neurologic problems after surgery, posterior cervical surgery with big laminectomy defects. All right, guys, have a great day.